Now moving on to our fourth section, we are continuing with the breathing difficulties and pulmonary trauma. In this section, we are briefly discussing some of the other life-threatening injuries. We have just discussed tension pneumothorax, massive hemothorax, but we'll be discussing pulmonary contusions, flail chest, and disruption of tracheobronchial tree in this section. What is pulmonary contusion? It's basically a blunt force trauma, usually associated with if there is no penetrating wound and patients maybe blunt force trauma to the chest wall, or it could be a crushing injury. This is usually leading to edema and hemorrhagic lungs. Leads to collapse and consolidation, ventilation perfusion mismatch, and patient may be hypoxia. If there are massive pulmonary contusion, patient may be having a severe ventilation perfusion mismatch, which eventually leads to profound hypoxia, and usually is bilateral with acute respiratory distress syndrome. How to diagnose pulmonary contusions? Initial is actually chest x-ray, but not reveal extent of contusion. For example, if you see this slight haziness over here, but it's not actually relieving extent of contusion. So mainly the diagnosis is based upon the mechanism of injury, how much was the velocity in the car crash, degree of hypoxia, how much ventilation perfusion mismatch is there, and oximeter saturation reading. Is the patient able to maintain his or her SATs or not? And then our ABGs actually estimate that there is hypoxia associated with hypercarbia or hypoxia associated with hypocarbia or not. Then coming to the treatment. Treatment is actually indicated at it's supportive. The patient is given rest, is given analgesia, is given oxygen so that it allows the body to recover from that problem. Oxygen administration, elective ventilation is actually done, and pre-existing pulmonary disease is actually always taken into account. If a patient had some kind of blunt trauma and patient already had a COPD, and then probably that patient will not recover to an extent which a normal young patient who had some kind of pulmonary contusion would recover. So we have to keep that in mind. If there are diseased lungs, then the recovery may be slightly slower as compared to the normal lungs who had a pulmonary contusions. Now coming to the flail chest. This results in the multiple rib fractures. If there are 2-3 ribs continuously fracture from 2 different points, this is anteriorly and posteriorly. This gives them this kind of a segment becomes flail or free, which can expand or collapse accordingly. So this is called as reverse or loss of structural integrity, because there's a fracture over here and the fracture from behind as well, leading to actually this whole segment in between is free and is mobile and can move freely without any structural contact. This leads to paradoxical respiration. That what happens is a normal patient, when the patient inhales, the lungs expand, but these rib structures, as they are free, therefore during the inspiration, instead of coming out, they go in, and once the patient exhales, the normal chest cavity goes down, but they come out. So this is kind of a paradoxical respiration leading to flail segment. This leads to hypoxia and ventilatory compromise. Respiratory failure may ensue, and eventually underlying severe contusions may be associated present as well. And we have to make it sure, because this pieces may, when they go in, they can damage the lung further. So how to diagnose? Diagnosis usually by clinical examination. Chest x-rays may reveal fractures and lung contusions. ABGs would be required to continue how much degree of hypoxia is present and whether we do need to manage accordingly. The management actually means administration of oxygen, because we have to ventilate the patient. Analgesics is important because there is associated rib fractures, which could be in form of epidural analgesics or intercostal blocks. Then if the patient is unable to maintain oxygen saturation and ventilation is not adequate, we may be requiring intubation of the patient, but usually it's not required. The patient is able to maintain his or her airway. IV fluids are usually avoided because already there is increased pulmonary edema and load on the lungs, which may further hamper the ventilation perfusion mismatch. Fixation of the fracture ribs is not always indicated, rarely indicated rather, and usually the treatment supportive, analgesia and IV, this oxygen is administration, and the patient usually goes along a long pathway, and eventually the rib fractures heal usually, but sometimes surgery may be required as well. Now coming to the disruption of tracheobronchial tree. Disruption of tracheal bronchial fistula, or if there was a presence of tracheobronchial tree, this can lead to presence of formation of tracheobronchial fistula. This actually leads to air leakage into the pleura, and diagnosis is by presence of persistent pneumothorax. The patient, despite having a chest strain, the lungs are not expanding, and there is the presence of a pneumothorax. There could be pneumomediastinum as well. On a chest X-ray, the air bubbles can be seen in the mediastinum as well, or pneumopericardium, and air below the deep fascia of the neck. In the patient, clinically, there will be crepitus, and in these areas there will be swelling, and air below the subcutaneous fascia of the neck area will be present, and usually seen in the decelerating injuries. The decelerating injury leads to tracheobronchial tree disruption. Immediate management. Immediate management is tracheal intubation, because we need to make it sure that patient is able to maintain his or her airway. If it's not to be successful, then we have to go for endotracheal intubation of the opposite lung, because the diseased lung will not be able to ventilate properly. Then could be use of bronchial blockers as well, or it could be before the adequate lung ventilation can be achieved. Sometimes we need a thoracic anesthetic as well, so that we can do a bronchoscopy and cause the bronchial blocker to be placed over there as well. Eventually the management is basically supportive, as well as the focus is always on the management of the airway. That is, the airway should be open and patient should be able to ventilate it, so that the hypoxia can be prevented. Now coming to the simple pneumothorax. As you know, pneumothorax is actually collection of air in the thoracic cavity, which leads to collapse of the lung, eventually the hypoperfusion and ventilation perfusion mismatch. It results from air entering the pleural cavity, causing collapse of the lung with resulting ventilation perfusion mismatch and hypoxia. There's actually a difference between the tension pneumothorax and simple pneumothorax. There is no mediastinal shift. Cardiac output is usually maintained, causes lung laceration. Blunt and penetrating trauma both can cause simple pneumothorax, and thoracic spine fracture dislocation can also cause pneumothorax as well. Diagnosis is simple during the primary and secondary survey. The only difference is that there is actually absent breath sounds on the side of the pneumothorax. The chest X-ray would be show that there is actually increased blackness on that side. There is hyperpercussion note, hyperresonant percussion note on the side. But as in the case of tension pneumothorax, there was tracheal shift deviation towards the opposite side. In the simple pneumothorax, there is actually no tracheal shift or deviation. So there are only two signs, that is the hyperresonance percussion note on the same side of the pneumothorax and absent breath sounds. Definite treatment is with the chest drain, and intubation and ventilation may be required if a patient is unable to maintain his or her airway. But usually chest drains are more than enough, and definitively usually results in the expansion of the lung, and simple pneumothorax can be easily treated with a simple chest tube insertion along with the chest drain. Now coming to how to insert a chest tube along with the chest drain, which could be a very simple maneuver and may be required in diseases such as simple pneumothorax, tension pneumothorax, haemothorax as well, or even some cases of other causes as well. Now coming to we have to first confirm the correct side on the chest X-ray. We have to be sure whether the problem is on the right or the left side. Then identify the fifth intercostal space on the affected side, that is usually above at the level of the nipple. Prepare with the skin with a 2% chlorhexidine of 705 isopropyl alcohol or alcoholic iodine. That is actually, you have to basically sterile the area, because chest may be skin may be containing different organisms, and we do not want to introduce infection into the thoracic cavity. Infiltrate skin and subcutaneous tissue with lignocaine. 2 to 3 centimeter horizontal incision is actually given above the 6th rib. So it's important in a normal anatomy of the human beings. If these are the 2 ribs, The neurovascular structures go just below the border of the upper rib. If this is the fifth rib and the sixth rib, if you give incision at below the lower border of the fifth rib, you may damage the neurovascular structure. So normally what is done is in the fifth and sixth intercostal space, we give the incision on the upper border of the lower rib, that is the sixth rib, so that we can go up towards the fifth intercostal space. Bluntly dissect through the subcutaneous tissue, insert little finger through the incision into the chest cavity, and grasp the tip of approximately size thoracostomy tube. Usually it's a 28 French, a 30 French is utilized, and we pass it actually in such a way that eventually the tube is passed into the fifth intercostal space. Once we attach that tube to underwater drain, which is important, that underwater seal is highly important, otherwise this air will not actually come out and the chest drain will be ineffective. Then we suture the chest drain to the place and apply dressing and check the lung for reinflation with chest x-rays. And usually the first thing is we get an x-ray to see whether the tube is appropriately positioned, and within few days the lung re-expands, and once the lung re-expands and ventilation is adequate, we can take out the chest tube. Now coming to the hemothorax. We discussed massive hemothorax in the last section. Now coming to the hemothorax. This could be caused by lung lacerations. This is usually damage to intercostal internal mammary vessels. Rarely requires operative intervention. And usually the most immediate management is passing of a chest drain insertion, and faster CT scan may be required. FAST is a part of the primary survey, but CT scan is only done once the patient is stable. Now the treatment is with large caliber intercostal drain or thoracoscopy. Well, that is also rarely required. But the first and foremost management of a simple hemothorax is passing of chest tube and chest drain with underwater seal. In this section, we have continued our different life-threatening injuries along with maybe associated with the chest trauma. We briefly discussed simple pneumothorax, hemothorax, and treatment for both of them is actually passing of a chest tube with chest drain with underwater seal. We have briefly discussed what are the other possible problems could occur, such as flail chest, pulmonary contusions, and what are the supportive management which can be done for those patients suffering from pulmonary contusions and flail chest. Thank you very much. Keep watching sqadia.com.